phone that is off mute. If you can mute your phone, that may help the echo. I'm unfortunately unable to mute a phone, so if you're able to mute yourself, telephone ending in 27, that would be wonderful. Shelley, if you can go ahead and do roll call, please.
All right, Alyssa Michael, Andrew Tang, Emily, Anthony Griffey, Tony Griffey, Brent Burgett.
Sorry, here for Tony Griffey.
Oh, thank you. Is Brent Burgett on the phone? Brian Stevens.
I'm here.
Charles who?
I'm here.
Right. Cliff Jones. Damian Johnson. David Natrika. Edgar Bissonette. Forrest Taylor. Franco Castromarin. Gail Bradley.
Present.
Dark Gamer.
Present.
Herman Butler. Iman Fizerfan.
Here.
Nick Ells.
Present.
Nirav Patel. Ryan Southworth.
Present.
Sandy Nygaard. Sean Felker.
Present.
Kara Johnson.
Present.
And Vicki Bennett.
Present.
We have quorum at 16.
All right, thank you very much, everyone. All right, well, good morning, everyone. Just a friendly reminder, if you can please keep your microphone on mute or your phone on mute. If you're off mute, it does create an echo. Also, friendly reminder, this meeting is being recorded and is shared to the Bureau's website. So anything said as part of this meeting is part of the permanent recording that is shared publicly. This includes anything in the chat or the video feed as well for the meeting. So the attendance report is in your packet. All right, let's see, figure out where that echo is coming from.
Okay, go ahead.
Okay. So the attendance report is in your packet. Just a reminder, if you missed 2 or more consecutive meetings, the Bureau will reach out to you to see if you're still interested in participating in the meeting itself. We would like to welcome 2 new members to the committee. First, Chief Taylor, welcome. And then also Damian Johnson, welcome as well. So thank you both for being here in person today. We have 3 reappointed members, and we actually, I'm sorry, 5, because we did receive 2 more this week as well. So Tara Johnson, Sean Boker, Nick Ells, Dr. Casperin, and Dr. Fizerfan. So thank you all for submitting your reappointment information. Congratulations on being reappointed to the committee. We have 1 current vacancy, a representative from a statewide rehabilitation facility. This is often a hard one for us to fill. So if you know anyone in that field from the hospital side that you work with, that would be wonderful if you'd like to refer them our way. If you have a term expiring in 2024 and any non-members are interested in filling a position, you can send a letter of interest in your updated CV or resume to Shelley Bissell. Her information is in the agenda as well. And these are a 3-year term appointed by the Director of ADHS. And then next, if we can open the Governor's Proclamation. So this is a very nice proclamation that was posted by the governor, just really acknowledging that this is Trauma Awareness Month, as well as EMS Week and EMS for Children Day. So a very nice joint proclamation from the governor honoring all 3 of those important factors for the state. So I just wanted to make sure we took time to share that with everyone in case you had not seen that. And next we will move on to the Bureau report. Chief Garcia.
All right. Well, good morning, everyone. We're going to be a little brief in our Bureau report today because we want to make some room for a presentation of awards. Like Dr. Bradley said, it's a very special month, and we want to make sure we are acknowledging that it's not just Arizona Trauma Awareness Month, but that we also are going to be presenting our first annual Trauma Provider Awards for the state of Arizona. So looking forward to that. We have a couple slides, of course, acknowledging the theme for this month. I think the next one, Shelley, is National Trauma Awareness Month. This theme of this year is injury prevention is everyone's business. And we certainly have compiled a lot of statistics and have some information available for anyone that's interested in our injury data. You all know, especially our State Trauma Advisory Board, that the department has been working collaboratively with the Trauma Advisory Board to develop dashboards that highlight injury prevention and some of the statistics that we see statewide. And we are happy to share that information moving forward. You also know it's EMS Week and EMS for Children Day, so we want to acknowledge those special events as well. And we'll be talking more about that as we move to the EMS Council meeting next. Michelle, you can advance a couple slides. Thank you to all of our clinicians and providers today. I'm going to give a quick rulemaking update for everybody, and then I'm going to pass the baton over to Carissa if she's on the line. You have Carissa here too.
I'm here.
Awesome, Carissa. So I'll go through just a couple more slides and then we'll get to yours. Wanted to highlight that we were very active in rulemaking over the last couple of years, as you can see. With the State Trauma Advisory Board, we thank everyone that participated and provided feedback, especially in the trauma center rules that were updated in 2023. We, of course, have some ongoing rulemakings that are highlighted on this slide. Of note, we are still working on our EMR and critical care scope of practice, our EMCT certification and training rules, and interfacility transport reporting requirements. So those are ongoing rulemakings, and we thank everyone that has provided participation in those. I want to quickly defer and just see if Dr. Bradley has anything to add with some of those ongoing rulemakings.
Just a big thank you to our PMD and MDC members who participated. We had a almost 4-hour-long meeting working on the scope of practice update to include EMR as well as critical care, and we had really robust discussion. I think this was going to be a huge benefit from the state, especially when we look at interfacility transfers and many of the trauma patients who do require a higher level of care. Having that ability to have now a true critical care standard in the state that agencies can then get reimbursed for, I think is going to really improve things. So we're excited that is, I think, at a near finished state. We just have to have that posted for public comment, and then those will go live on January 1st with the other critical care rules. So very excited about that and appreciate all the work of the committees who participated in that process.
Absolutely. So the next slide just says that we, of course, will keep all of our trauma advisory board and stakeholder updated as we move through the rulemaking process, so that if there are any additional stakeholder meetings or opportunities for comment, that information will be shared with everybody. And then additional state and federal updates, I will not cover these in detail. I just want to make sure you know in your packet that we've included information on our strategic planning process. With our next step, if you go to the next slide, being that we will come back to the Trauma Advisory Board in September with a draft strategic plan for the board to review and approve, and we look forward to working with you all on that, and thank everyone that has participated in our surveys, focus groups, and most recently our strategic planning summit in April. Next up, we just have a little bit of information about SHARE and the transition to the from the U of A to ADHS, and we look forward to giving more updates on that moving forward. And then some information about naloxone leave behind, and a recent campaign from the department is also available in your packets for folks to take a look at. I think the next slide may be Carissa's. National Registry updates, EMS trauma dashboard update, all that's in there for you all as we get prepared to look at some more fall data and work with, of course, the board on that. But then next we have Carissa. I'll turn it over to you.
Good morning, everyone. So as we know, ESO is sunsetting out our current registry project, Trauma One. So what that means is beginning January 1, 2025, there won't be any new updates or anything like that involving Trauma One, but we will have 6 months, so until July 1st, to complete all of our 2024 records. So ADHS posted an RFP and that closed on May 1st. So we are currently currently in the process of evaluating the bids we received. The goal is to have those evaluated and a decision made by July 1st. And then we are hoping to have the new registry system implemented at the state level and at all of the trauma centers by July 1st of next year. And ADHS plans on making or setting regular meetings with stakeholders to just keep everyone updated and to prepare for the new registry once we have a vendor selected. Yes, Vicki.
Hey, thanks, Carissa, for that update. Are you able to tell us the number of vendors that applied and identify them, or is that confidential?
Yes, so that is public record. It's on our APP website, but I can tell you we received 3 bids, one from ESO, one from Image Trend, and one from IQVIA.
Great, thank you so much.
Yes.
Thank you, Carissa. And so we'll direct folks that do have any additional questions to the website so that you're able to see information as we move along. And of course, we will be sharing updates on the trauma registry as we go through that process. I am also being reminded to plug our Gov delivery. If you have not signed up, we have information on our website. And of course, we can distribute that to all of our members and participants here today. It's the way that we blast out information, especially about the good work happening in the community with some of our awardees being honored today. So please sign up for Gov delivery. That's how we will get information out like what you saw today from the Bureau report. And with that, I think we'll give it back to Dr. Brown.
All right, thank you. And I will say for the GEP delivery, we promise not to spam you. We are quite selective of what we send out. When you sign up though, unless you would like to receive every communication for the Department of Health, which you surely can, I just make sure you dial down to the Bureau of EMS and Trauma System. Otherwise, you may end up getting quite a bit more communication than you wanted. But the system is quite effective. I think we have close to 10,000 people signed up. Is that correct? 9,000, which is, I think a few years ago, we were at 2,000. So it's a significant increase in people who are receiving our communication. So I wanted to just start off with saying last year we did our first EMCT of the Year awards during EMS Council, and we were hoping at that time to also try to recognize the trauma community, but it's a little bit more complex, and so we realized we couldn't pull it off in quite the short amount of time we were able to pull off the EMCT of the Year awards, but really wanted to work over the past year to create this award program for all the great work that's being done across Arizona in our trauma systems. And so we really appreciate everyone who took the time to nominate someone. We really feel that having the opportunity to acknowledge people for all their work is very important. We had a subcommittee that is external to ADHS that reviewed the applicants and made the decisions. So we recognize we are the regulators, so we were not the one that made the decisions on the awards, but I really think it's important to take the time to recognize everyone for all the great work that you're doing. So a big thank you for those who did nominate people. Dr. David Harden is going to be the one who will kind of read the awards and announcements. So David, I will turn it over to you.
I'm going to help out with the CWEX puddle.
Team effort. Like team effort.
All right. Well, yeah, as Dr. Bradley said, this is our first annual trauma award, so we're really honored to be able to stand here and present awards to this year's winners. My name is Julia Vincent, and I work in the services section of the Bureau of EMS and Trauma, along with David Harden. So we are kind of the people in the Bureau that do not regulate, and that's why we're presenting the awards this morning. But we're very honored to be able to do so. And we'll kind of read a little bit of the nominations that were submitted for the winners and then present plaques. So I will be doing 4 of the awards, and then I'll hand it over to David. So without further ado, we'd like to present the award for the Trauma Program Manager of the Year for Level 1 Trauma Centers. And this award will be going to Wendy Otten. This morning, I will just provide a little oh, come on. Come on up. I'm so sorry. So sorry. Whenever we announce your name, please come up so that we can get you. Trauma Program Manager for Level 1 Trauma Center. So the Trauma Program Manager of the Year award is going to individuals that are really have an outstanding commitment and dedication to the Arizona Trauma Center. You were selected as this year's winner because of your outstanding commitment and dedication to rendering critical trauma care and service to Arizona's residents and visitors at a level 1 trauma center. So just a little bit of the nomination that was submitted for you. Sorry, see this paragraph. Wendy's commitment to excellence has been evident through her involvement in numerous committees, task forces, and projects aimed at enhancing trauma care delivery and patient outcomes. Wendy's collaborative spirit, coupled with her role as a mentor and educator, exemplifies her commitment to advancing trauma care practice and fostering a culture of excellence. Wendy's passion for trauma care is palpable in every aspect of her work, from committee involvement to training initiatives and quality improvement projects. Her unwavering dedication to advancing trauma care standards and her ability to inspire and empower those around her make her a truly deserving candidate for Trauma Program Manager of the Year. Welcome. Congratulations, Wendy. So second, we have the Trauma Program Manager of the Year for the Level 3 Trauma Center, and that is going to Sherry Fugate. So again, you are selected as this year's winner because of your outstanding commitment and dedication to rendering critical trauma care and service to Arizona's residents and visitors at a Level 3 trauma center. So Sherry is a phenomenal trauma program manager for Banner Bell E-Web Medical Facility, a Level 3 trauma center, as her can-do attitude, incredible attention to detail, innovative data collection, and disciplined focus has improved our trauma program. You single-handedly done a lot of things. It sounds like a lot of quality improvement. You can read through the nomination. And just recently was given a new full-time position that has approved her to assist in expanding the program even more. Sherry is a wonderful asset to our community. She has grown the program and recognized the barriers within our hospital and community and provides injury prevention workshops and more. Congratulations. And at the end, if we could have you guys all take a photo with the board, we'd love to grab 12 for a photo. All right, Trauma Program Manager of the group. Trauma Program Manager of the Year for a Level 4 Trauma Center goes to Heather Miller. So as I said for the other two winners, you were selected as this year's winner because of your outstanding commitment and dedication to rendering critical trauma care and service to Arizona's residents and visitors at a Level 4 trauma center. So just a little bit about your nomination. In her role as a trauma program manager and pre-hospital coordinator for Kingman Regional Medical Center, Heather runs the Trauma Performance Improvement Committee, Injury Prevention Training Center for EMS agencies, and collaborates with multiple community agencies. Heather is a member of several ADHS counseling committees, including the EMS Council, Trauma EMS and Performance Improvement Committee, and more. And is also the secretary for the Western EMS Council. Heather is passionate about training and educating fellow ED nurses and hospital staff, EMS, fire, police, and community members in many aspects of trauma and medical patient care. Heather serves her community with compassion and commitment and supports the community hospital in multiple ways. And next, we'd like to present the award for the Trauma Medical Director of the Year, and this will go to Dr. Jordan Weinberg. All right, so you were selected as this year's winner because of your commitment and dedication to managing a reliable trauma program that renders critical trauma care services and personnel to Arizona's residents and visitors. Just a little bit from your nomination. Dr. Weinberg is a trauma medical director from St. Joseph's Hospital and Medical Center and a professor of surgery Creighton University School of Medicine, Phoenix Regional Campus. Also a faculty physician with Dignity Health Medical Group at St. Joseph's Hospital Medical Center. Dr. Weinberg is extensively published in his research, taking a special focus on trauma resuscitation and pathophysiology related to transfusion in the trauma setting. He's a reviewer on a number of editorial boards, a member of several professional societies, including the American Association for the Surgery of Trauma and the American College of Surgeons. And then it kind of goes on to list a lot of committees and various entities. I'm sure you'll be here for this. Congratulations.
Next award is for the Trauma Registrar of the Year award. Goes to Tina Krum. A lot of stuff to read. All these people, all these great things you folks are doing. Okay, this year the Bureau's Collaborative Trauma System Stakeholders host the first annual award for trauma. This award is issued to Tina for her work as a Trauma Registrar of the Year. Tina Krum has been a trauma registrar at Havasu Regional Medical Center for the last 7 years and is an example of our hospital's core values. Tina sits at the heart of the HRMC's trauma program. She cares about her work and pays attention to even the smallest details to ensure data accuracy and trustworthiness, bedrock of our registry systems. Tina goes out of her way to help others learn and grow and never backs down from a task, no matter the size. Tina is a valued educator in our injury prevention program, is currently working on becoming an RN and a trauma nurse. Tina just received her certificate, her CNA certificate, and is now in her first semester of nursing as a nursing student. Tina volunteers with the HRMC's Injury Prevention Committee and Disaster Committee. Well, thank you and congratulations. Next award is for the Injury Prevention Achievement Award for 2024. It goes to Sean Broker. Again, this is just a summary of the accomplishments and work you're doing on behalf of your stakeholders and the Arizona citizens. Okay, the following is a partial summary of your award nomination form, which highlights your remarkable performance and inspirational to all of us. Sean has 26 years of experience in her profession. She thinks outside of the box to deliver community prevention projects. For an example, she initiated a fall prevention program at Flagstaff and Verde Valley called Tai Chi Matters of Balance. That's a good program. To enable geriatric patients to maintain better balance and strengthen their muscles to reduce falls. Sean has secured grant funds for several projects, including $25,000 to purchase bleeding control systems for Flagstaff Unified School District, and grant funds for harm reduction vending machines at the Flagstaff Emergency Department stocked with free naloxone kits, fentanyl test strips, medication disposal kits, safer smoking kits, and safer sex supplies. Sean actively performs research on health topics like naloxone distribution compliance with access, naloxone DAP program, off-road vehicle injuries, and sledding injuries. He volunteers at community events like the Anchors Away to Health, Safe Child Coalition events, and Night to Shine, and has been a Northern Arizona EMS representative for the State Trauma Advisory Board and the State Trauma EMS Performance Improvement Committee for many years. So accept on this on behalf of all of us. Congratulations. Thank you. final category is for Research Academic Achievement Award for 2024 goes to Dr. Kumroff. Hope I said that correctly. Right. Now, this is just a following summary of your achievements on your nomination form submitted by your peers. Christina Kumanoff, PhD, is the Director of Clinical Research and a biostatistician in the Trauma Department at St. Joseph's Hospital and Medical Center in Phoenix. Dr. Kumanoff holds faculty positions at Creighton University School of Medicine and University of Arizona College of Medicine. She has a long list of publications and conference presentations contributing to new knowledge on trauma patient outcomes, including 91 peer-reviewed papers and 27 conference presentations, supporting the trauma team at St. Joe's. She's a fierce supporter, supports graduate medical education in Arizona, and has been recognized for her dedication to new medical learners in Arizona. Medical residents learning, supporting surgery residents, research projects, and getting residents on podiums at conferences. She has taught research methodology and statistics and has led journal clubs for medical students and residents for the past 4 years. She also founded a monthly journal club for residents and medical students open to any Valley learner interested in going into medicine. Yeah. Congratulations. Thank you.
Thank you so much. We so appreciate you guys being here today to cheer on all of our amazing trauma awardees. We have Megan Thomas that just joined us, and we'd love to get a photo of all of our honorees today with the board. If everyone can come back up, we'd love to get one photo off of you. I think we're having a little trouble with the cameras. I don't know if you want to use your phone, Megan?
Yeah, I'll use our icon and we'll grab our alternate later.
And for the board members, kind of watch the cords, but squish in with us for a photo. That'd be amazing.
Rachel, with or without flags?
With your plaques. Please bring your plaques.
Would you like us all in front of the table? Would that be easier for you? Okay.
Best friend.
Don't throw my board.
Thank you.
I know. I
Style.
Yeah.
Everybody just look at this.
Absolutely.
All right, yes, let's give us a hug.
So everyone get in.
Or maybe a couple of the taller guys can go in the back.
Then we got about four in there. All right.
What a gorgeous.
Ready? 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
I want to thank you for the nice congratulations in the chat as well. Shelley has been displaying those. And Sean, I love the Go Cats, despite representing the northern region. So, all right, well. Sure. So what we did last year was for the ENCT of the Year Awards, we did have the opportunity to take a picture with Megan, if you'd like, downstairs by the state seals. If anyone would like a more formal picture done, you are more than welcome to have that done as well with your family. So thank you for indulging us with that today. It is nice to take the time to give some positive reinforcement and all the great work being done. We look forward to doing this again next year. So I hope to see more nominations coming in as well. I think we did have one area that we did not receive any nominations for, which is more of a focus of pediatrics. So keep that in mind. We do want to focus as well on our pediatric trauma patient population. And that was one we did not receive any nominations for. So for next year, if you're trying to think of who to recognize, that might be a nice category to bring up as well. So we will keep moving along the agenda to our standing committee reports. Sean, for a TEPI report.
Sure. So our TEPI meeting, we established a quorum. We had our minutes approved. We displayed slides for the share data elements and the PEAP status. Approved as amended goes to EMS Council in May. Christina Kupinoff presented a slide and information on wanting an umbrella data sharing agreement with all trauma hospitals for data for research. There was a great deal of discussion, interest from some centers, but not all centers. So there's more to come on that. Dr. Bradley gave a background on wanting to capture fentanyl when possible for the trauma registry. Carissa shared that it is an option to pick in your drop-down list, and actually we are using that data right now. And then Gail and Botzel shared the updated data visualization pages for off-road vehicle injuries and falls incidents, and there's more to come on that as injury prevention programs ramp up. And Vosbrink shared AZ Peers HB 2609 reporting requirement information. She's also posted a document, response times by urbanicity report information and guidance to her AZ Peers webpage under the tab Education and Tutorials. And then after that, we adjourned the meeting.
Thank you very much. Next, Sandy for Education Committee.
Sure. So we met on November the 23rd and the minutes were approved as presented. The March 24th special meeting minutes were approved as they were presented. Training was also approved as amended. The training was for EMCTs for patient fall prevention, which has been posted. The Alzheimer's Association presented info on their first responder training product. Training was approved to add to the training resources webpage, and that's posted also. Training updates approved as amended for Leave Behind the Lock Zone. Request to add the QR code line for that, and that has been completed. Dr. Gaither presented Arizona quality, excuse me, for chest pain, stroke, and TBI quality improvement, and that was approved. The sepsis training program was also approved as amended, and Julia displayed the updated slides, 41 slides, and that have also been posted. The table updates for the chest compression only CPR needed updated data on slides 11 to 12. Dr. Bradley recapped the March 14th special meeting. Jason Johnson shared potential loopholes for critical care research, and no new work groups were created. Thank you.
Thanks, Sandy. Next, Dr. Casper for PMD.
Good morning. Two items. The first one was the regularly scheduled PMD meeting that was held on March 21st. We approved our November 2023 minutes. Dr. Bradley recapped the March 14th special meeting regarding rules with a new iteration of draft rules expected in the next week or two. She also prepped the group for the meeting on May 1st. For updating EMCT scope of practice. More on that in just a second. And then Dr. Davis presented info regarding finger thoracostomy as an STR skill for the paramedic scope of practice table. But a point of order was made because it was mischaracterized on the agenda. And so that topic was then placed on the agenda for May 1st. So that takes us to the May 1st special meeting. The members approved adding to the scope of practice in Arizona, including a new column for the EMR provider, a new column for paramedic with critical care endorsement, a line for intranasal route unit dose pre-measured and removed STR for paramedic on the thrombolytic line. They also adjusted table 1 EMCT drug box to add an EMR column, as well as a paramedic with critical care endorsement column. A draft drug table 4 was tabled, and then also a draft drug table 3 was tabled.
Heather for Trauma Program Managers Workshop.
So our last Arizona Trauma Programs Managers meeting was February 23rd at Phoenix Children's. It was a great meeting with state updates. They did a lecture on pediatric trauma, and then they actually did injury prevention, OHV training, train the trainer class. Our next Arizona Trauma Program Managers meeting is tomorrow at Valleywise.
Thank you. Next, Adam for PACES.
Hi, good morning. This is Adam. Let's see. So PACES last met on March 21st. Minutes were approved. Jordana Carpenter was voted as our vice chair. Aubriana gave us updates about the EMSC team's continuing efforts to generate a pediatric pre-hospital recognition project, and as well as the National Pediatric Readiness Assessment is now open, and this is a survey that EMS agencies can use to find out how pediatric prepared they are. The window for this assessment is open for 90 days starting 2 weeks ago about, and I can share that link in the chat, but that's all I have for PACES. Thank you.
Thank you. All right, next we will move to our discussion and action items. If I can get a motion to discuss, amend, and approve the meeting minutes from January 18th. I see a first from Dr. Casperin, second from Sandy. Thank you. We can reject the minutes.
Yep.
Thank you. Are there any recommended amendments? Hearing none. Any opposed, please say nay. Any abstentions? All those in favor say aye.
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 Thank you. Next, we have as a standing item on the agenda, but I know Dr. Patel was not able to join us today for an update from American College of Surgeons Committee on Trauma. I don't know if there's anyone else who is able to give a report on that. Otherwise, we will defer it to September. We will defer. Thank you. Next, if we can get a motion to discuss and amend and approve forming a work group on fall data and injury prevention to include requested data items. This is tentatively scheduled. We had put a hold on everyone's calendar. We just unfortunately did not have it as an official request. That's why we couldn't form the work group, but we did put it on hold on everyone's calendars a couple months ago. So if I can get a motion to form that work group, please. Thank you, Sean. Can I get a second? Second. Thank you. So just a little bit of background on this. We had really, I think, probably the most discussion we've had at STAB in well over a decade at the last meeting, which was great. And we've had kind of increasing conversation and discussion of how we address fall injury and kind of from an injury perspective for the public, education for EMS providers, as well as things of like looking at data for patients who go to trauma centers versus non-trauma centers. And so we wanted to make sure that we really gave this group an opportunity to work with some of our other committees as well and bring together for this kind of towards a task force per se. So we do have the hold that was sent out on everyone's calendar. So everyone should have received that for June 20th from 9 a.m. to 11 a.m. That will be, again, always we have in-person and virtual option. We do want to make sure that we are making good use of people's time. So we wanted to open this up to see what specific elements the group would like us to address in that committee. I know that Vatsal has shared quite a bit of her data. Shelley, if you can maybe click on the fall data dashboard, just to give people an opportunity to kind of see what we currently have built, or when I say we, I really should say Vatsal, what Vatsal has built in terms of addressing some of the questions that have come up regarding falls, and wanted to open that up to the committee to see what specific topics people would like addressed. So as that opens there. So you can see here, you can adjust by year. You can do a ground level fall versus falls from height. You can do all falls or then falls with hip injury. So you can isolate it that way. And then you can also adjust by age group. One of the other components we have is severe falls. So when we click in that tab, and this is severe fall cases from ASTR data. And if you can scroll a little bit, you can see kind of substance use related as that overlaps with some of our falls as well. So this is kind of the data set with, over the last year and a half as this group has requested things to be added to our fall data. If you recall, we used to do kind of the 20 to 30 page PDF State Trauma Advisory Board annual report, and then really have moved to this more dynamic dashboard, which allows people to not only kind of look at the data themselves and adjust based on their region or county, but it also gives us the opportunity. We had a number of things that were requested after this was published.
Was healthcare innovation.
Kevin says hi. So after we published the last report last September, this committee had quite a few questions. And so Voxel was able to take that feedback and then kind of build and add this to the report. So as we build the agenda for June, we just wanted to see what specific items this group would like us to kind of put in there for discussion amongst that group. Yes.
TNS injuries with fall, brain and spine separate, maybe. And by the way, your falls, that's based on the injury that occurred with the fall, the severity, or is it the severity of the actual fall?
I believe that is injuries. Let me double check. I believe I saw Voxel on there. Make sure I do not misspeak. Voxel, can you answer that question?
Good morning, everyone. So you are asking about the severity, right? The severity is based on what?
Yes.
Okay.
Is the severity, yes, is it based on the severity of the fall, meaning height, or the actual injury? Yeah.
Correct. Now, so actual injury, so what you see on the first tab, that comes from all the data, falls related injuries from the hospital discharge database. And because we do not collect all the falls in the trauma registry, for me, I mean, where the layman can easily understand, it was easy. I just use the terminology severe falls, meaning that they come from trauma registry, rather than coming up with like all the inclusion criteria and how to define that. So severe falls means all the falls which are submitted in the trauma registry, has nothing to do with the injury severity score. Yeah, and it says over there.
I have a follow-up question. So is it correct to say, since the first tab is all hospitals and all falls at all hospitals, and the second tab, it sounds like it's just trauma centers.
Exactly.
We have, it looks like about 200,000 falls when we look at all hospital data and about 30,000 when we just look at trauma centers. Is that the way to read this?
That is true.
Okay. Thank you, Rocco.
So then I think I'll ask the follow-up question. Are you looking for us to define severe falls based on injury severity scales?
I would define it differently. I would probably define it level 1 trauma falls, non-level 1 trauma falls.
How do we account for then patients brought in by EMS where there's not a proximity to a trauma center, but they otherwise would have qualified?
That is usually captured when they get transferred to a level 1. So that's usually those will typically get captured at their secondary trauma center.
Okay.
So they would still fall into the bucket. It just wouldn't be from their primary arrival.
What we can also do,
Severity.
sorry, we can also put a filter over here on the trauma page, ASTR page as a level 1 and all other trauma center. Just so we can choose level 1 and look at the picture, and we can choose non-level 1 basically.
And so the goal for today is just to get some topics. So I like that we're getting topics. We don't have to come to kind of a consensus. The hope is that we can really take the opportunity in June to kind of look at positives and minuses for some of those different things. But I wanted to make sure if I'm asking you guys to come in for a 2-hour meeting, that we make it worth your while. So I wanted to make sure we at least have some good agenda topics to talk about.
I think one important thing would be to classify falls into the ones that are back to baseline with ambulation after the fall, and the ones that do not go back to baseline with after the fall, where there is an immediate change in status, to identify the 2 separate groups. Because in a second one, where they fall and the patients don't go back to baseline level of mobility, and yet that does sort of flies under the radar, and we don't look closer into it, and underlying injuries may get missed, such as, let's say, cervical myelopathy or whatever.
It's kind of though biased based upon what they say they are. So I can't tell you how many people, mom was a community ambulator and clearly mom needed a walker and barely got out of her home. And so I think we're biasing our pre pre-injury status based upon their thoughts. And my thought pattern and bias is that they overestimate how well they do compared to what they're actually doing.
The other challenge would be, do we define it as 30 days out, 60 days out, like, or how do we define if they're?
I would define it as sort of after the initial assessment when you're ready to discharge, whether from the ER or, here's the thing. Although that is all very challenging, but you have some good identifiers. Let's say somebody was walking without assistive devices, and now you have to send somebody home with a front wheel walker. You have to at least give a pause and see, okay, is it just the recovering, or is there more into it? Or somebody was, walking with a cane, and now you have to send out in a wheelchair. I mean, a big objective change in status.
But again, I think they're biased in the fact that there's a surgeon, I'm biased as a surgeon, and my colleagues do present them or advance them with non-weight bearing. For me, that means I'm in a wheelchair walker. I can't, I'm old enough, I'm not gonna be non-weight bearing versus someone who advances them. And most geriatric people, you wanna advance them, whatever you do to something of full weight bearing, because if not, they're stuck in a wheelchair. So again, I think we're biasing what their outcome is based upon what their surgeon or discharge provider tells them as their mobility status, which may be nothing to do with their injury and ability to ambulate.
But then whoever assessed them though, that's then the physician has assessed them and determined here, you'll be non-weight bearing. And then, you do that, but at least there was an assessment. Here, all I'm saying is this: people go in with cervical myelopathy, they're falling. And then with every fall, they can get a little worse with a little spinal cord injury. That may not be bad enough to be detected. Kind of flies under the radar. 6 weeks later, I see them in clinic. So yeah, I had a ground level fall ever since. I need to use a front wheel walker. My balance is off. You get an MRI, and I have that. And that was not detected at presentation, just as something to catch that better. That's all.
So I think, I think these are good things we can kind of talk about. And that's something that we can figure out how can we capture the data if possible. As you saw, the one vacancy we have is a representative from a rehab facility. So I think that's, potentially some of the gap in our data is having representation from that community. But certainly from the trauma centers, would love to see how you capture that data with patient discharge. So Vicky, I saw your hand up as well online.
Yeah, just a brief comment. As we're doing some of these statistics and we're looking at level 4, level 1 data that had been mentioned, I just want to make sure we include a way to know what was transferred and not, so that we don't count patients maybe twice, or at least that we define how we are counting it is all.
Sounds good.
Gail, I'd like to add that I would like to find a way where we can better track lift assist calls for EMS, because the index fall is usually sort of the tip of the iceberg. The person falls, the EMS shows up just to lift, assist, get them back up off the floor. They're not injured. And then EMS goes away. The patient never gets transported. And this can happen 5, 6, 7 times before the patient actually gets injured and goes into the hospital. So I'd like to kind of look at a way we can better track that, standardize it with EMRs, and then figure out how we can tie some of these EMS calls into these patients that we then see ultimately once they get injured, sort of see how many times this is happening, etc. Because there's some good data that says that once they start getting that lift assist call, they just sort of tank after that.
And I think maybe part of that is the next agenda item, which is the education piece for EMS providers of kind of what the risks are associated with fall. We will certainly add that to the agenda. I will tell you my gut feeling is that we probably will have a lot of challenge like connecting that, because it's really going to be very dependent on how that call was coded by that EMS agency in regards to primary impression, then try to link that later on to, that might be a little bit of a challenge, because it's easier for patients transported to the hospital. Then we have an actual patient with a run sheet that goes to the hospital that also can link via the hospital discharge database or ASTR data. When it's a non-transport, that's a little bit harder to figure out how to link that data with the call. But certainly good items for us to talk about as well as from an education perspective.
It'll also be difficult because a lot of times the fire department, the fire engine respond, not the ambulance. And they don't always, they have a separate form and they don't know if that's captured in our data. So they usually respond and then, you know, if it's a non-transport
in our data, but it's gonna be hard to potentially link someone who's not transported. How do we know that that call is something that we can then correlate with a call a month later?
Well, and that's why I think standardizing it in the NIMSIS dropdown with just one or two items for selection would be really helpful, because then that's easy enough to pull data on. Whereas right now it can be listed as this or this or this or this, and it's all over the map. So nobody has any idea of just how often this is happening and how resource intensive it is for these fire agencies or EMS agencies.
Yes, I will say, for those of you who are not familiar with NEMSIS, NEMSIS is the National EMS Data Standard. So that is the data standard that is a national level approved at kind of a national committee, and is a very active participant from the state of Arizona in that committee. We have our AZ peers data, which we make sure is compliant with NEMSIS data, but we have to stick with the national standard. So limiting that down is probably not going to be something we can do, but we do, just for anyone who's not familiar with the term NEMSIS, that is the National EMS Data Standard that is utilized in the EDCR. So I've got some defining severe falls, looking at CNS injuries, both brain and spine, status after fall. How do we define this? Potentially looking at tracking lift assist. I know one of the other things that had come up was anticoagulation use. I think that would probably be of interest as well. Is that something the group would like us to add to the agenda? I see head nod, yes.
And what we're talking about right now is primarily elderly falls, but I have some interest in pediatric falls as well. We have a lot of, they're kind of all over the map. So I would like to see if we can figure out how to break those down into different groups. So you have kids falling out of windows, kids falling off of playground equipment, things like that. So I'd kind of like to drill down on that a little
Oh,
more.
that's great. We definitely, that's a very good, we will make sure we include that, because certainly this is part of, when we look at falls, it's, we have if you maybe go back to the dashboard, we do have pediatric specific data on that dashboard as well. So yes, if we can look at pediatric things and how we want to focus on that a little bit more as well. Let me look, I see Sarah Latham in the chat. So crisis response, community response for frequent calls and training. I think that gets into some of the stuff. Prevention work.
The other tab too.
I'm sorry.
Can you do the other tab by pediatric as well?
Oh, sure.
The falls related discharges one.
Just scroll down on the regular one. Sorry, the falls. So you can see here pretty large volume, despite the the 0 to 17 age group. And if you scroll down, you can see unfortunately we do have deaths in that group as well. Some of this data, if you scroll a little bit further down, I believe we had to kind of hide the data because it got too small with a couple of these elements with the young patient population. So sometimes if it's grayed out, it's just because the numbers get too small. It could be identifiable. Yes.
Someone there at the meeting from social work type of thing, because I think it's getting to what you're talking about. It's, if you find the canary in the coal mine for some of these people, and maybe if they do have a call for a fall, that they have a follow-up kind of home assist type that checks to see what their environment is, carpets on the floor, stairs, needing assisted devices, shower stool, bars, all those things that kind of a lot of these people seem to have repetitive type problems with. I think it'd be nice to have to kind of close that loop.
That is a great idea. So certainly for the trauma centers, if you have someone in your facility that is interested, that would like to participate, please, these meetings are all open to the public, so please bring them in person, or they can join virtually. There are still a couple community paramedicine programs that do focus on a little of some of this work. So I will see if I can get a representative from one of those as well. That really does a lot of this type of evaluation too. So I think that is a good ground rule. We have plenty of time to still work on the agenda. So if you think of anything else you would like us to cover from a topic perspective, please email either myself directly or Shelley, and we'll make sure we add that. But again, want to figure out kind of how can we create some good positive work moving forward to address the falls. So. Pardon? Oh, yes, we do need a vote to officially form this work group since we did not do that last time. So we had a first and a second on the floor. Anyone opposed to the formation of the work group, please say nay. Any abstentions? All those in favor say aye.
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 All right, next, we are going to do, wanted to review the Education Committee, Education for Training EMCTs for Fall Prevention. So a big thank you to our Education Committee and Dr. Rice, who chaired that subcommittee to really develop this training. So this was something that we put together really as an opportunity for EMS agencies to use this and go live with this data. I wanted to let this committee know, I know this committee had asked for some specific education for EMS and fall prevention. I think EMS does go on a lot of minor fall injuries and lift assist patients. Many of the times these patients do not want to be transported, but we did feel there was an opportunity to do some education. What can you do to educate the EMS provider and make them aware of things like, hey, if you see them on the floor next to a rug and that's what they tripped on, offer to roll off the rug, identifying that is the potential trip hazard. I think EMS does a lot of these things that they don't even think that this is fall prevention, but you guys are out there in the field doing this work, but kind of putting that term and saying this is really EMS prevention, just like the fire services fire prevention, little things that can be done to help prevent some of these recurrences. So the training is really nicely put together. It is available and posted to our website, but just wanted to make this group aware in case you're looking to do any outreach with your EMS agencies. We do have this educational curriculum put together that can be used for some fall prevention work. So a big thank you to Dr. Rice for sharing that and getting that completed. You want to scroll? Are you scrolling? Sure. Just scroll down a little bit. Okay. And on many of the slides, we do have speaker notes that if someone's trying to kind of identify what is the point we're trying to get across with some of this training, we do have speaker notes embedded in there to help address some of that.
Flagstaff.
And then one of the things we really wanted to identify is just helping to pick out those high-risk patients. If a patient's on anticoagulation and they had a minor fall but hit their head, recognizing that this is potentially a patient who's higher risk. Also wanted to make sure we identified doing things like a basic, hey, if you get up and normally walk and you fell and we helped you up, let's not just get you back into bed. Let's make sure you can still actively walk. Sometimes just getting the patient up and having them ambulate a few steps will find you can't potentially actually ambulate safely. So this is a lot of the part we wanted to include, making sure people are aware and able, with many elderly patients, you have to ask a little bit more questions, especially if it's in the middle of the night. They may have a little bit worsening of their underlying dementia, confusion, that they have the ability and capacity to make their own decisions. So that is the training. If anyone is interested, the link to that is on our agenda as well. All right, and then the last action item, if we can get a motion to discuss, amend, and approve making an advisory statement on the State Trauma Advisory Board annual report to include fentanyl testing and reporting as part of the Arizona State Trauma Registry to address substance use disorder in trauma patients. Very long motion. Can I get first and a second, please?
I'll motion. Second.
Thank you. All right. So just a little bit of background. I think I have brought this up in that right now there is the option, and most trauma centers are reporting substance use disorder. But for many centers, unless you order a separate drug screen for fentanyl, it's not identifying that in your standard urine drug screen. We do recognize that fentanyl is the most common opioid that's in the substance use disorder patient population often right now. And so how does that affect kind of patient outcomes? And so we wanted to really make a statement. We can't change what is required data elements for trauma as part of the trauma registry that is outlined in statute. So we can't change that, but we can certainly, through Chris's work that she does with the trauma registrars, I really want to get the word out there and wanted to see, and this group wanted to kind of make that formal recommendation in the STAB report in September to hopefully kind of emphasize the importance of gathering that information in your institution. That is the background on that. Any questions or discussion about that? Everyone in support of that? Not. Okay. Anyone opposed to that very long motion, please say nay. Any abstentions? All those in favor say aye.
Aye.
Aye. Aye.
Next up, any agenda items to be considered for the next meeting. We will have our state trauma annual report, so we should have quite a bit of data to share in the September meeting, but we will also have our strategic plan that needs to come to this group as well. So we will have a pretty full agenda, but if there's anything else you would like us to cover, please let us know. You can email either Shelley or myself directly. Next call to the,
Yes, one thing for next meeting. Could we please, and Vatzel, this is Manny for the data. Could we please do a summary of mortality with particularly severe head injury, GCS 8 or less, covering after COVID to the immediate years before COVID? I think we had an increase. I just want to know whether it was a temporary increase in mortality or whether it was just a fluke incident.
so mortality for GCS less than 8 pre and post COVID. And then I guess since we are having a little bit of a wave right now with COVID, what would you like to define as the time frame for post COVID?
2020 included 2020 and forward versus 2019 and before. And just roughly up to 2019, these mortality with GCS of 8 or less was less than 40 consistently, and come 2020 and afterwards like 45%.
Okay.
So there was a jump of more than 5%, and I think for 2 successive years. I think it's because of gunshots. I'm not sure, but that's maybe one thing to maybe have a peek at next time.
Okay. I found that down. Thank you. Any other topics for the next meeting?
Etiology too. Closed versus.
That's a good idea.
So yeah, I was thinking, you know, to the level of EMS resource use. I wonder if we can eventually discuss ways to measure that, hours, calls per month, et cetera, for things like lift assist, because then eventually what that may do is show that we need additional resources in communities, funding in communities for things like community paramedicine programs or social work or fall prevention programs that we can do in communities to prevent using constant fire and EMS resources for lift assist.
I don't know. I like the idea. I think that probably has to be done at the agency level because we have no way of knowing we get the run sheet. That's what we get. So we have no way of knowing what someone's staffing model is, what their call volume is. So it would be really, I think, probably impossible for us to extrapolate that from the data we get, just because we don't get any of that information that's really agency specific.
Recognizing those limitations currently, I think it is a way we could maybe strategically plan to capture data moving forward by standardizing how it's reported and letting agencies know that we're interested in this level of information. And I think that might at least help get data moving forward. There's nothing we can do now.
Just to make sure, because I know Vatzel her brain will start ticking in how to do this. But Anne also is who runs our AZ Peer system. We don't collect any information regarding our units on things along those lines. So I don't think there's any way to capture that in AZ peers or NEMSIS.
It'd probably have to be a voluntary reporting system down the road. We know how well that works.
We got almost 1 million records a year for many years in AZ peers on a voluntary basis. So that was actually pretty successful, but I don't know that type of data. That might be a little bit challenging just because it would be a whole secondary set of data. From an agency perspective, please speak up. I don't know. I may be speaking for you, but I don't know that there's a way to easily capture that or produce that in AZ peers, like in your EPCR platform. Oh,
That would have to come from an internal QI process working with trauma programs, because you're right, it doesn't support that anyway through any of the NEMSIS fields.
In NEMSIS fields, would you be able to capture if it's consistently reported as one or two things in the NEMSIS dropdown for a lift assist, and then time of service, so the time you're called versus, and then the time that the service ends? That would go to AZ peers, yes? So then we could at least get that level of data, how long they are on the scene and the type of call, and we could at least get that.
I'll see Vince and then Ann has her hand raised.
It would be lost in the noise of the routine calls across the system. It'd be really hard to capture that.
Ann, I see your hand up.
I just wanted to address the topic of being able to find lift assists. There's not really a specific way they're easily found, but I think the larger issue may be that we don't have a way to tell agencies specifically that lift assists need to be reported. It's not one of those things that's laid out that way, because we tell them they need to report EMS calls, but if they don't consider that lift assist a patient or a patient call, and I realize that seems a little strange, but also we have the same issue sometimes with canceled calls. We ask them to report them if they are recording them, but if the agency doesn't consider a lift assist a patient and is not recording the call, I don't think we have, besides encouraging them and saying, could you please report them to us? I'm not sure how many agencies just don't document lift assists at all. That would be one of my concerns.
And then I see a hand raised as well from Brian.
Hi, good morning, everyone. It's Chief Stevens from Tucson Fire. Good point, because our calls used to come in, somebody would call and ask for, I just need help getting up, I'm weak and things like that. And we used to use a lift assist or an invalid assist code. And what we found is a lot of people were going, I think Shelley brought it to the point, we go there, we pick them up, and that was it. 2 weeks later, we're back. And then a month later, we're back for some other event. And so it's this progression of whatever this underlying condition they have. So we've gotten away from it from Tucson Fire as far as, we call it what it is. If somebody's weak, it's weakness, and it comes in as a fall or weakness. So it kind of takes the bias out of the crew going there at 2 o'clock in the morning. Are like, I just got to pick this person up. And we ask our folks, we educate them. Dr. Gaither's really big on the lift assist. We offer service, we offer assessment, and if they don't want an assessment, they get a refusal. So we try to make our folks at least do some vital signs and get a good patient assessment, and then encourage them, to seek further medical care. And then also the part about the, just the fall prevention. We have a program, TC3 down here, where our folks will make recommendations for those homes that are, somebody could use some extra services just for fall prevention, education, or whether it's bathroom, grabs and door things like that, just to help them out. So it's tough to, I think it's going to be tougher to search it, because there's no actual lift assist code, so to speak.
So I think this is a great agenda item for us to really kind of put on the agenda to talk about. And I think this leads into the education that the education committee put together, was really focusing on what many of us as medical directors have done for years with our EMS agencies, which is to focus on the importance of treating patients like a patient and doing an assessment, doing vital signs. And I think the education committee did a very good job. So that is part of what we can kind of package as part of the discussion as well. Maybe share some of those resources statewide for agencies that don't have it in place. All right, next, call to the public. Upcoming events, there are a number of upcoming events listed on the agenda. I will not read through all of those, but please look through those if you're looking for some continuing education. There are many options on there. Our next meeting is in September, on September 19th, 2024. It will be virtual and in person again. And we will share the 2025 meeting schedule then.
I have to make the schedule.
Yes. So we will do our best to avoid as many conflicts as possible. It is always tough to avoid everything, but we do try to avoid any of the major conferences.
They did recently changed the date of the Southwest Regional Trauma Conference. That's now moved to August, I believe it's the 1st and 2nd.
Okay.
I can let Shelley know.
Looks like I have it down wrong.
No, you had it right. They've changed the month. And it came out yesterday.
All right. Yes, David.
I can't remember, but I know in June, there's a rural conference taking place, rural health conference in June 5th, I think it is. It is. Okay, good. Thank you.
If I can get a motion to adjourn. Thank you very much, everyone.
I've been looking at, that opened my eyes. I didn't realize that they don't actually code them. And that the one Phoenix